Hello, my name is Morie Gertz, and I'm a professor at the Mayo Clinic in Rochester, Minnesota. And I'm here to review with you transthyretin amyloidosis and how to make an early, timely diagnosis so that therapeutic intervention can have meaningful impact. Transthyretin amyloidosis is rare, progressive, and invariably fatal, and is caused by the deposition of amyloid fibrils into multiple organs and body systems, leading to their dysfunction. In ATTR amyloid, the most common organs involved are the heart and the peripheral and autonomic nervous system. ATTR amyloidosis is an abbreviation for amyloid transthyretin amyloid. Transthyretin stands for the transporter of thyroxine and retinol binding protein, and it is an unstable protein that will dissociate and form amyloid fibrils. There are two types of ATTR amyloidosis. One is the wild type, in which there are no mutations present, and that form of amyloidosis is from the deposition of amyloid fibrils composed of wild type TTR, and this is typically a disorder that involves the heart, leading to congestive heart failure. 85% of are men, and the majority are over the age of 60, and most over the age of 70. There's a second form of ATTR amyloid, which is a hereditary or mutated ATTR. And here there's deposition of mutant TTR throughout. And depending on the mutation, it could be dominant heart or dominant nervous system. The clinical presentation can be quite broad, and a typical patient could be a 68-year-old man with progressive lower extremity numbness. A patient will come to your office, say, I feel like I'm walking on thick pile carpeting, as the first manifestation of sensory loss in the lower extremities, reflecting the developing length-dependent sensory neuropathy. A 58-year-old male can present with bilateral carpal tunnel syndrome that can often predate the diagnosis of amyloidosis anywhere from 5 to 10 years. Impotence is common as a reflection of the autonomic neuropathy. Patients will come because of loss of sensation. If they have cardiac involvement as well, they'll often have lower extremity edema due to the high filling pressures in their heart. A third patient that might come to your office is a 66-year-old man who complains of dyspnea on exertion for approximately 1 year, and there's a history of carpal tunnel syndrome. Or a 55-year-old man who develops palpitations or arrhythmia while running with no prior history of cardiomyopathy. Amyloid can involve almost any system. When it involves the nervous system, it tends to cause a length-dependent sensory motor peripheral neuropathy that leads to weakness and falls. In patients where the autonomic system is involved, you can get orthostatic hypotension, you can get sexual dysfunction. Patients who develop progressive neuropathy will develop secondary muscle weakness or neuropathic pain or difficulty with foot drop, walking, and fall risk. Some mutations of mutated ATTR can deposit in the vitreous of the eye, and the vitreous amyloid can cause significant visual loss. Sometimes the amyloid will obstruct the drainage canals, glaucoma will result. Cardiac involvement with amyloid can be both the myocardium itself, leading to heart failure with preserved ejection fraction, or it can involve the conduction system, causing AV block or atrial fibrillation. Autonomic involvement of the nerves regulating bowel function can cause pseudoobstruction with nausea or vomiting, or intractable alternating constipation and diarrhea with a significant risk of fecal incontinence. Early satiety and weight loss are common. In late stages, the kidney can be involved, leading to nephrotic range proteinuria and loss of renal function. When we talk about the epidemiology of ATTR amyloidosis, there are only estimates. It's a very rare disease, and it's estimated that worldwide there are approximately 50,000 individuals who have the hereditary form of ATTR amyloid. Some of those estimates suggest 10,000 have polyneuropathy, 40,000 have cardiomyopathy, but by and large, there's a significant overlap with 2/3 of patients having both nerve and cardiac amyloid. ATTR cardiac amyloid is thought to be significantly underdiagnosed because systolic function is preserved and the echocardiographic findings can mimic hypertensive cardiomyopathy or a congenital left ventricular outflow obstruction, hypertrophic cardiomyopathy. Median age and onset is 68 years of age, but anywhere from 48 to 88 can be seen. Life expectancy highly variable dependent on the extent of cardiac involvement, but can range from 3 to 15 years. But it's influenced by the genetic mutation, patient's age at diagnosis, what part of the country they're from. The ratio of men to women is highest in the United States at 4.6 to 1. There is a registry for patients that have TTR amyloidosis. In this registry, the most common mutation varies by region, but in the United States, it's a V122I mutation. This mutation localizes specifically to the African American population, and the carrier prevalence of the gene is from 3.5% to 4%, and is therefore quite common. The clinical course of amyloid polyneuropathy will start with pain and loss of sensation in the lower extremities, but as it progresses, the neuropathy will ascend, begin to involve the upper extremities, lead to motor weakness, and then eventually, as it progresses, these patients will become wheelchair bound. And as the heart becomes progressively involved, refractory congestive heart failure, refractory to diuretics, develops, and these patients typically succumb due to congestive heart failure. It's an autosomal dominant disease, and progression occurs noticeably every year from onset until death. The neuropathy can be painful because the amyloid can affect the small unmyelinated nerve fibers that affect pain and temperature. The large myelinated fibers, when they're damaged, affect muscle strength, and so these patients have significant problems with falls. Bowel and bladder disturbances and sexual dysfunction are common. Towards the end, for most, although not all mutations, multisystemic involvement occurs, involving the heart, the nerves, the kidney, the bowel. The clinical course is a bit different between the familial form of amyloid cardiomyopathy and the wild type of TTR cardiomyopathy. Both have similar symptoms of heart failure that are very nonspecific: shortness of breath, palpitations, arrhythmias, lower extremity edema, weight loss due to heart failure, nausea, fatigue, dizziness, disrupted sleep. So very nonspecific and consistent with many causes of cardiomyopathy. When these patients are followed, their last 24 months are characterized by repeated hospitalizations for the management of diuretic refractory heart failure. Median time from diagnosis to death in the Mayo cohort is 3.7 years. And basically, the patients go from a functional status, New York Heart Association 1, and as time goes on and the myocardium becomes progressively infiltrated, they begin to develop progressive loss of cardiac function. You see cardiac biomarker increases, both the troponin T and I, as well as the BNP and the NT-proBNP, which are very sensitive markers of cardiac dysfunction in amyloidosis. Wild type cardiac amyloidosis is present and almost certainly severely underdiagnosed because it occurs in an elderly population that have a high prevalence of cardiomyopathy and because the symptoms mimic other forms of cardiomyopathy. In autopsy series in men over the age of 85, grade 3 and 4 amyloid deposits are found in the heart in 25% of patients. When patients who are having carpal tunnel release, men over the age of 50, women over the age of 60, amyloid stains done on the released flexor retinaculum shows amyloid in 10% of patients. Patients who are hospitalized for heart failure with preserved ejection fraction, who are over the age of 60 and have a ventricular septal thickness of greater than 12 are diagnosed with TTR cardiac amyloidosis in 13%. Routinely screening patients with severe calcific aortic stenosis reveals cardiac amyloid TTR in 5%. And patients who are referred for transaortic valve replacement who are screened have cardiac amyloid found in 16%. In our laboratory, before a patient can have a transaortic valve procedure, they have to be screened for cardiac amyloid to ensure that the valve replacement will result in clinical improvement in the patient's heart failure. So TTR amyloidosis is a great pretender. Over 40% of patients are misdiagnosed initially. And surveys have shown that patients will go 3 to 4 physicians, averaging 1 to 2 years before a diagnosis is made. This is in large part related to the broad spectrum of symptoms: carpal tunnel syndrome, polyneuropathy, irritable bowel syndrome, heart failure, spinal problems such as pseudoclaudication due to lumbar spinal stenosis, plantar fasciitis, fibromyalgia, all diagnoses these patients will have. Only half of the patients will actually give a family history for the mutated forms of ATTR. And because many of the patients who have this come on age 70 to 80, family history isn't useful because all you'll find is that a first-degree family member died of heart failure. The key for this discussion is how to recognize the disorder and how to screen to ensure the diagnosis isn't overlooked. Presenting symptoms are highly variable, but the most common for patients who have wild-type TTR are shortness of breath and fatigue, lower extremity edema, all manifestations of their heart failure with preserved ejection fraction. Hereditary ATTR have the same symptoms of dyspnea, fatigue, and edema related to the heart, but they have superimposed problems of peripheral neuropathy, weight loss, orthostatic hypotension, and syncope. And so a very broad spectrum. And so one of the keys when a cardiologist sees a patient who has heart failure with preserved ejection fraction are inquiring about carpal tunnel syndrome, peripheral neuropathy, spinal stenosis. Conversely, when a neurologist sees a patient with an unexplained length-dependent sensory motor peripheral neuropathy, attention to dyspnea on exertion, orthopnea, lower extremity edema that requires diuretics helps clue one into the fact that this is a multisystemic disorder, not a heart problem, not a nerve problem, but a multisystemic problem. So we'll talk about an example patient. A 68-year-old man, progressive lower extremity numbness, chief complaint, I feel like I'm walking on carpeting. Patient saw a neurologist and an EMG confirmed a mixed axonal and demyelinating neuropathy. The patient was screened by the neurologist for diabetes and heavy metals. It was negative. Conclusion, idiopathic peripheral neuropathy, placed on observation. But over a year of observation, the sensory level rose from the soles of the feet to the calf. At that point, a skin biopsy was performed, in part to look for nerve fiber dropout, and it showed amyloid deposits. Then the patient is referred to a hematologist, And then the hematologist took it from there, and we'll review that briefly later. Our second patient was 58 years old with a history of bilateral carpal tunnel syndrome 6 years earlier. Certainly, carpal tunnel syndrome is very common in the general population and is often related to repetitive stress injury. But a right-handed individual will typically have right-sided carpal tunnel, and a left-handed individual left-sided carpal tunnel. But when you see bilateral carpal tunnel, that should raise a suspicion of a systemic disorder. Our patient also had erectile dysfunction for 3 years and came for evaluation of the sensory loss in the lower extremities with some edema. EMG confirmed neuropathy. The patient's edema was empirically treated with furosemide 20 milligrams daily, and it took over a year for his diagnosis, and we'll come to that in a bit as well. Our third patient was a 66-year-old man who was previously healthy without a history of hypertension. Bilateral carpal tunnel syndrome was diagnosed 10 years early. Patient saw a cardiologist. The cardiologist showed changes that were consistent with infiltrative cardiomyopathy, raising the question of amyloid. The patient's ejection fraction was slightly reduced to 40%, and the biomarker NT-BNP, brain natriuretic peptide, was markedly elevated to 1,121 when over 300 reflects heart failure. The patient received diuresis, lost 7 kilos, and much improved. Neuropathy did not change. Our fourth patient, the 55-year-old male, complained of palpitations while running, underwent a exercise treadmill test that was negative, but it did reveal non-sustained ventricular tachycardia. 6 months later, the patient had an echocardiogram, and a diagnosis of non-obstructive hypertrophic cardiomyopathy was made because of the dramatic thickening of the left ventricular free wall and septum. The patient was placed on a beta blocker, and family screening for familial hypertrophic cardiomyopathy was recommended. 9 months later, our patient saw a new cardiologist. The echocardiogram was interpreted and felt to be consistent with amyloid. So clinical pearls to think about this disease is that ATTR amyloidosis is a pretender. And there is a very broad spectrum of symptoms, but the common themes are family history of neuropathy or heart failure, bilateral carpal tunnel syndrome, the presence of a cardiomyopathy, typically associated with infiltration and preservation of the ejection fraction, and then the loss of lower extremity sensation. And if you take this into account, you can actually be suspicious, which can lead to early diagnosis and early therapy.